Hello, everyone. My name is Jaydira Rivero. I am a medical oncologist as well as an endocrinologist at the National Cancer Institute. It's my pleasure today to be the moderator of a tumor board and how net experts treat liver metastases.
I'm Singh. I'm a surgical oncologist with a keen interest in neuroendocrine tumors, and I'm a hepatobiliary and pancreatic surgeon as well. I'm based out of City of Hope in Phoenix.
Hi, everyone. My name is Osman or Ahmed. I'm an interventional radiologist at the University of Chicago with a particular keen focus in interventional oncology.
Hi, everyone. It's great to be here. My name is Dr. Erik Mittra. I'm a nuclear medicine physician at Oregon Health and Science University in Portland, Oregon. I'm also the chief of the molecular imaging and therapy section and director of the radiopharmaceutical therapy program. It's great to be here. Thank you.
As we can see, we have an excellent panel today. And with that, we're going to discuss our first case. This is a 46-year-old male who presented to the emergency department complaining of epigastric pain. A CT scan of the abdomen reported a 15.8 centimeter pancreatic TELT mass with multiple liver lesions and with the greatest dimension being 3 centimeters in size. CT scan guided biopsy of the liver mass reported a grade 2 well-differentiated neuroendocrine tumor with a Ki-67 of 15%. So this is the scan of the patient. And Dr. Mittra, as we're showing the scans, could you please describe what we see in the scans and what would you recommend as the next step?
Sure. So for evaluation of these types of tumors, especially for staging, but also restaging, both CT and MRI have a very important role. So this is the MRI that was done, and it's particularly good for the liver and for the pancreas, which is exactly where this patient has their disease. And so you can actually see the very large pancreatic tail mass, as well as multiple enhancing lesions within the liver, which are likely the metastases that are there.
I'm fond of MRIs, but I think sometimes when you're looking for vascular definition, I prefer a good CT for anatomical purposes and for planning surgery. I think a good CT for vascular definition and a delayed, 20-minute delay on the EOVIST phase for the burden of liver disease.
And Dr. Singh, for our patients, could you please describe what is SMA and what is relevant in this case?
So the SMA is the superior mesenteric artery, which supplies the entire intestines. And so it is critical to actually make an effort to save that, because if you compromise that, you're compromising the vascularity of the entire small intestines and 2/3 of the large intestines. The celiac axis, on the other hand, has 3 dominant branches. One goes up towards the liver, one goes up to the stomach, and the third goes up to the spleen and the body and tail of the pancreas. So once again, it's a good idea to save the celiac axis and not take it, although you can reconstruct these vessels. But I think it's always a better idea to have before you go into the operating room as to, do you have the degree of freedom to be able to resect these without needing complex vascular reconstruction?
Okay. Dr. Mittra, anything that you would like to add?
No, I just wanted to reiterate Dr. Singh's point that, both CT and MRI, as I mentioned, have an important role for the evaluation, but they do have different pros and cons. I think for patients, it's important to understand that in either case, it's important to get a multi-phase CT or a multi-phase MRI. Oftentimes, patients only get one phase, and that's not quite sufficient to evaluate all the different things.
And Dr. Oz, anything else that you would like to add in this case?
Not much. I think it's a great discussion. I would probably echo a lot of what Dr. Singh said as a vascular interventional radiologist. We are particularly keen on getting CTs for vascular planning. And I would agree that this mass looks like it's well away from the SMA and celiac axis. It does look like it's draping over the splenic vein, but I imagine the spleen is easier to sacrifice than other parts of the body.
So I think it's important to get good vascular definition on these scans, and particularly if the mass is encroaching on the superior mesenteric artery, which supplies almost 2/3 of the intestine, large intestine, and the entire small intestine. It's important to make sure that the mass is away from that so it can be safely removed. And with regards to the celiac axis, that actually has three dominant branches, one that's going up towards the spleen, one to the stomach, and the other towards the liver. And once again, it's a good idea to actually save those blood vessels in surgery when you're doing that, except for the splenic artery and vein, which is going to come out in continuity with the mass itself. You can do complex vascular reconstructions, but you like to be well prepared ahead of time before you go into these operations. You want to make sure you have good vascular definition on your scans before you go into the operating.
And what I'm hearing in the discussions, especially in this case, that we have a patient with a pancreas, large pancreas mass, and liver lesions consistent with neuroendocrine tumors. And it seems that based on the discussion, surgery is an option. Would you recommend anything more, any other scan prior surgery?
I'm actually fond of making sure that these are somatostatin receptor positive scans, tumors, because that determines a lot of the adjuvant treatment. So a good gallium-68 PET scan is in order, I think.
Mm-hmm. And as we can see, this is the 68 gallium dotatate scan. And Dr. Mittra, could you please describe what we see on the scans?
Yeah, so this scan is targeting the somatostatin receptors that are expressed on these tumors, and based on the key 67 of 15%, you would expect that most of these tumors should have high expression of somatostatin receptors. So it's a great thing that's an adjuvant to the CT scan or MRI scan to see, what the expression there is. And as we're scrolling through, you're seeing all of those same lesions on the liver, in the liver, as well as the large pancreatic mass that are showing that high uptake. The pancreatic mass also shows some areas of not high expression, which are probably necrotic, or areas that have actually died within the tumor. And you can see that as sort of the holes within there as well. And you can probably make out some lymph nodes locally as well.
And can I ask you a follow-up question? Some of our patients ask whether there is any difference between 68 gallium dotatate scans or 64 copper dotatate scans. Could you please describe more in detail whether there's any difference or if any preference, one versus the other?
Sure. So there's a lot of technical differences, but I think the bottom line that patients should understand is that there's these two different isotopes, gallium-68 and copper-64. Both of them are targeting the somatostatin receptor, as we just talked about. And if the scanners are set up properly for the isotope, then essentially they're equivalent as far as imaging quality and effectiveness. So I don't think patients should really be worried too much about that. There are technical differences between them in terms of the half-life and the energies and things like that. But more or less, either one is good as long as the institution is set up for that.
Great. Thank you so much. Based on this information, Dr. Singh, now we have this patient that have a pancreas neuroendocrine tumors with liver metastasis. You already saw the dotatate scan, which is avid, so the tumor expressed the receptors. So what would you do next? Well, what would you recommend next on this patient?
The most important thing is to take the primary out. That is one single action that promotes longevity, okay? Whether you touch the liver, you don't touch the liver. A lot of groups have published that, including our group. So that's one thing. So she would end up with a distal pancreatectomy with splenectomy, for sure. Now, since there's no vascular reconstruction, and if the first portion of the operation is fairly straightforward, I'm a proponent of doing the liver at the same time. And as long as you think you can achieve in today's day and age what we say 70% reduction of the total liver tumor volume, somewhere about 8 or 9 lesions is what I calculated, but there might be more, which would definitely be more obvious on a 20-minute delay on the MRI. If there's no vascular reconstruction necessary, then I tend to do the liver at the same time. If there's going to be some major vascular reconstruction, I like to do it as a staged fashion. There is no data to suggest that the staged liver resection is anything wrong. So if you don't feel comfortable doing it at the first sitting, or you think the surgery's already been fairly major, it's absolutely fine to stage it and do the liver in 6 weeks to 3 months.
Great. And Dr. Oz, as an interventional oncologist, do you think that's something that you could address via liver-directed therapies, and when would you recommend?
Yeah, that's a great question. I would echo what Dr. Singh said, that, in our practice, we would probably prefer, if there is a surgical option with respect to obviously the primary, but also to the liver, to try to debulk as much as possible, especially if the tumor burden is feasible enough to do that. I think the role of interventional radiology or oncology here would be twofold. One would be if Dr. Singh, for example, felt that he could get 80% of the tumors, but maybe a few would be difficult to reach, then we could potentially offer local regional therapy like a percutaneous ablation. And or if he felt that the tumor burden was too high to address surgically, we could also offer what we call intra-arterial therapies, which are under that umbrella include things like bland embolization as well as radioembolization.
Great.
I would like to add one more thing. Usually at the time of surgery, I tend to debulk them surgically. You don't need a margin on these tumors. All you need to do is enucleate these tumors. So it's like taking a hard-boiled egg out of a shell, basically, but you're not leaving any residual tumor behind. So you can do that safely. A couple of the deeper lesions you can ablate in the operating room at the same time. But I think what Dr. Oz just said is there are sometimes you're left with disease that you cannot get to, or you're going to be pushing the envelope a bit too much, and not leave enough liver behind. At that juncture, you then put a pause on it, and then do that either in a stage fashion, or you get your interventional colleagues involved to address that disease while they're on systemic therapy.
Great, thank you so much. Just as Dr. Singh recommended, this patient did underwent a distal pancreatectomy, a splenectomy, and cholecystectomy, meaning that the distal pan of the pancreas was resected, the spleen was resected, and the gallbladder was resected. Pathology was consistent with a grade 3 well-differentiated neuroendocrine tumor, so the Ki-67 is 30%. As we discussed earlier, the Ki-67 was 15%, but now we can see that the final pathology said that it's 30%, and there was lymph nodes that were also positive for neuroendocrine tumor. Patient then have a follow CT scans. The liver lesions were unchanged, and the patient was started on lanreotide every 4 weeks with a follow scans every 3 months. After 9 months of being on lanreotide, follow scans revealed that the tumors in the liver grew, and at that moment, lanreotide was stopped. And Dr. Mittra, what would you think? Would you do any other workup for this patient based on the Ki-67, based on what we see in here?
Before I answer your question, I'm curious what your answer is. How often do you see that the Ki-67 changes, and what does that mean to you from an oncology perspective?
Right. So the initial Ki-67 of 15% was from a biopsy. And sometimes when the biopsy is done, it's possible that maybe they could biopsy a necrotic area. And sometimes when there is a necrotic area, sometimes the percentage of Ki-67 cannot be accurately calculated. So in the fact that this patient underwent surgery and there is a lot more tissue to kind of review this number. So I do believe that this Ki-67 is more accurate, and it was 30% from the very beginning. And I feel like the initial Ki-67 that was done from a biopsy, is possible that there is more necrotic tissue and unable to accurately calculate, as I said. But now that this 30% seems to be more accurate, and 30% is what I think has been from the very beginning of the diagnosis of neuroendocrine tumor. But yes, that's a good question. Yeah. Sometimes I get the question that I get a Ki-67 and a biopsy of this percentage, and then a repeated one is higher. But usually our decision is to always take the highest Ki-67, because as I said, sometimes, the lower Ki-67, there may be an area that there was, like I said, necrotic tissue. And as I said, the call of the pathologist to calculate this number. But I do believe that the higher Ki-67 is the more accurate for the neuroendocrine tumor.
So let's say if the Ki-67 came back at 30% on the initial biopsy, based on the new data that's coming out with CAPE-TEM, would you start the patient on CAPE-TEM to see a response and then go to surgery? or would you still want us to debulk it and then go to surgery?
All our recommendations for our patients with neuroendocrine tumors, as we all discussed, is multidisciplinary. And I think it's important always to have our surgeon, nuclear medicine, interventional radiologists, medical oncologists, because it's not one size fits all. And I think we all know that. So the treatment of neuroendocrine tumors is quite personalized from patient to patient. And in this situation, yes, I do agree that systemic therapy is an option. And the reason why is because of the volume of disease. It's important to know as well what is the volume of disease. It's important to know whether the tumors are only in the liver or outside the liver, whether they express somatostatin receptor, because that also will guide us as well as what therapies are recommended. But in this situation, because we can see there's a large pancreatic mass, large multiple liver metastases, I do think that in this situation, to my first line of therapy will be CAP10, just to see if that also shrink the tumors, because we know that the tumors can shrink up to 40%. And if we can do that, maybe it's possible that surgery it will be easier later on. But in this situation, yes, I think I will have opted to start capecitabine temozolomide.
Yeah, so this brings up a couple of interesting points. So one is that we did see that area of necrosis on the initial scan. So what you said about the biopsy makes a lot of sense. And in addition to that, always the surgical biopsy is generally more accurate than the ones that are done with the core. Now we know that the patient has progressed based on the CT scan already. So just for that reason alone, it would be important to potentially restage again with a somatostatin receptor PET, the dotatate PET, to see what is going on now. And then also because the Ki-67 is increased, as the number goes higher, you begin to lose somatostatin receptor expression. At 30%, I would still expect to see good uptake, but it would be good to reevaluate that. And on the scan, as we're going through, you're seeing many, many more liver lesions than you saw previously. The majority of them appear to be still showing somatostatin receptor expression, but it would be very important to correlate that very closely with the CT or MRI to make sure that some of these small lesions are not beginning to lose the expression that was just mentioned. And then you also have their FDG scan, and that also starts becoming important as the Ki-67 starts going up, especially above 20%, because you start losing somatostatin receptor expression, then those lesions will start having increased glucose uptake, which is what the FDG scan shows. So many people advocate that it would be ideal to do both types of scans to fully evaluate all the different tumors and what is expressing what.
Right. Thank you so much, Dr. Mittra. And as you suggested, this patient did had glucose scans, and the glucose scans is on the top end of the picture, and then the dotted scan is on the bottom. And as we can see in this patient, is still highly expresses somatostatin receptor, which we know that is the tumor is positive on somatostatin receptors. It can open also the possibilities of other therapies as well. But as you suggested, I think, you say like, well, we need to sometimes do both the scans to really understand more about the biology of these tumors. Maybe there may be some tumors that may be more dotatate avid, and maybe some tumors may be more FDG avid. But maybe if you could, for our patients, maybe to discuss more in detail, when would you do the two scans and how that help us to make clinical recommendations?
Yeah, in a very general sense, sort of rule of thumb, if Ki-67 is less than 20%, you can probably get away with just the dotatate PET scan, as long as you correlate with the CT or MRI and you don't see any discrepancies there. Above Ki-67 of 55% on the opposite end of the spectrum, you almost always want to go with FDG scan, and it'll be less likely to show the dotatate expression. And then, but that still leaves a very wide range between 20 to 55%, where again you might need to do both types of scans. And the best advice I can give again is to correlate it with the CT and MRI. As far as like therapeutic decisions, if you have somatostatin receptor expression, as you're alluding to, that opens up those types of therapies such as somatostatin analogs and PRRT. Whereas the more you lose that and the higher the FDG uptake goes, then you're not going to be well served with those therapies, and you'll want to do other types of systemic therapies such as CAP10. In this case, like you said, the FDG uptake is very, very low compared to the dotatate. So that's very good.
And one last question. Sometimes our patients have difficulties getting both scans approved. If there is any recommendation, anything that you will suggest, for our patients, or how to approach their physicians in order to get the scans done whenever it's needed?
Yeah, that's a really important point, and illustrating for ourselves as well as for patients. And I think a lot of the difficulty is the fact that they're both two different types of PET scans, and insurance companies often see them as sort of in the same bucket, even though they're completely ultimately types of scans. So oftentimes it's just an education with the insurance company, and having them understand what is the benefit of these two different types of scans, as we just discussed. So doing a peer-to-peer evaluation discussion with the insurance company can sometimes help alleviate that, but it is a problem, and also there's a lot of regional variability with that as well. But the first thing is to kind of understand the importance of it, and then secondly is to kind of push for it with the insurance company.
Thank you. So just to follow up with our case, this patient did get a combination oral chemotherapy with capecitabine and temozolomide, and capecitabine was discontinued due to coronary vasospasms. And what does that mean is when your heart artery suddenly constrict, causing spasms that trigger symptoms like a heart attack. It very rarely occurs, it's less than 4%, but it has been documented. So this patient only got temozolomide alone for 2 more cycles. And as we can see on these scans, there was evidence of the tumors grew, and there were more tumors seen on the scans. And maybe that will be a question for Dr. Oz. What would you recommend here?
This would be an ideal scenario for an interventional radiology intervention, particularly because the bulk, if not all of the disease, seems to be confined to the liver, which is where most of our therapies are sort of confined to. Given the amount of tumors and the distribution of the tumors involving both lobes of the liver, we would typically favor doing something intra-arterial, meaning we go through the artery, deliver it stage it into 2 procedures, right and left lobe. And we, in our practice, typically do what's known as bland embolization. So we would inject basically inert particles that would occlude the arteries and basically starve the tumors of their blood supply.
And could you please explain the difference between bland embolization, radioembolization, chemoembolization, because we know that there is different type of embolizations, and why would you recommend bland versus radioembolization? I know that some of our other colleagues may recommend radioembolization, and the question will be, if that's an option, when would you recommend that?
Yeah, that's a great question. I think the procedures are all very similar in that the idea is that the tumors with neuroendocrine cancer are hypervascular, and hypervascular is a fancy word for they get a lot of blood flow or a lot of blood supply. So we take advantage of that by going into the artery of the liver and directly and injecting some material. And that material could be basically, like I said, just like grains of sand, just bland beads. That's called bland embolization. You can mix those beads with chemotherapy, and or you could inject radioactive microspheres, and that's called radioembolization. It's a form of radiation therapy. The sort of why one is picked over the other, a lot of that will just be variations in practice of the IR that you're seeing. And a lot of it is also just preference of the surgeon that you may be working with. The reason that we particularly like bland embolization is because A, it gets good results, but B, you can repeat the therapy with little to no sort of collateral damage to the liver. With neuroendocrine cancer, radioembolization has become a little bit less favored because it causes sort of underlying liver damage. And we talked about other therapies like PRRT and things like that, where, that will also directly target tumors and may cause some liver damage as well. So we want to try to minimize that as much as possible. And fortunately, because neuroendocrine cancer patients have generally a favorable prognosis, we want to minimize the chance of a patient developing cirrhosis down the road. So we favor bland embolization because it tends to sort of cause less collateral damage. It doesn't mean that you can't have radioembolization, but more often than not, that will be sort of, at least in our practice, would be more of a bailout if the bland embolization didn't seem to work well.
Thank you so much for that answer. And Dr. Mittra, the fact that, we have these tumors very avid on DOTA scan, and this patient have not received 177 lutetium DOTA, would you recommend in this situation?
Yeah, it's a great question, one that is very, very relevant right now in terms of the data that's coming out from several clinical trials, such as NETTER-2, which is a big one that included patients with this type of high-grade tumors, but still expressed somatostatin receptors exactly as this patient does. At our institution, this patient would exactly go, as Dr. Oz is saying, between sort of these options. So the tumors are, as he said, looks like either entirely or mostly limited to the liver. So liver-directed therapies would be a great option, but also because they're so somatostatin receptor avid, they would also potentially be a good candidate for PRRT. So that would, I think, be the big discussion point at our institution. And in often cases, it would go between one versus the other. It's just a matter of which one is done first.
Thank you so much. I think it's important to know and make our patients aware of the data with the NETTER-2 that it was given in the first line setting and for higher grade neuroendocrine tumors, and they saw that the tumors did shrink with that, and I think it's something that needs to be discussed as well with our patients.
Can I ask a quick question to the interventional radiologist? So,
Right.
do you tend to target the bigger lesions first and then leave the smaller lesions for the nuclear medicine people to take care with PRRT? Or do you randomly go after one side and then the other side? How do you plan treatment with bilobar disease like this?
Yeah, great question. So the answer is somewhere in between. So we do treat the whole liver when we do bland embolization if you have tumors in both sides. If you only had it on the right or on the left, we would only treat that half. Typically, when we're doing interventions for neuroendocrine cancer, and if we're doing one of these arterial therapies like bland embolization, we're doing it because there's widespread tumors. If you only have a few tumors, then we're talking about surgery versus ablation or even something like histotripsy. So because we're doing it for patients who have tumors everywhere in their liver, more often than not, we will do what are called lobar infusions. So we go into the right hepatic artery or the right side of the liver, and we inject the beads very proximally or very far away from the tumor and distribute the beads throughout the entire liver. Because the tumors are very hypervascular, meaning they're like vacuum cleaners, they kind of suck up those beads as you inject them. We indiscriminately inject those beads. So the intention is to treat all the tumors on that side that's being treated. And then we would repeat that procedure for the other side of the liver, 4 to 6 weeks. The side of the liver we typically start with is the side that typically has the most tumor and the largest tumors. So more often than not, that tends to be the right side of the liver, but not uncommonly, we start with the left.
So with the bland embolization, do you feel that the smaller tumors completely go away and the bigger ones get a little bit smaller? What is your experience on that?
Yeah, I would say that's generally what I like to tell patients to expect is don't focus on the tumors disappearing. Focus hopefully more that these tumors are like light bulbs, as we've seen on these scans. We want to basically burn the light bulbs out. We want to basically get rid of the blood supply to them. So what we see more often than not is that those larger tumors, yeah, they may shrink a little bit, but we don't want to see them enhance or get contrast on the follow-up scans. Similarly, the tiny tumors, hopefully because they're so small, they may disappear, but we're looking for sort of a lack of enhancement more than anything.
Dr. Mittra, you wanted to make a comment?
Oh, I was just going to ask what your opinion is in this case between liver-directed therapy versus PRRT.
Right. And yes, we discussed this case in our tumor board, and we discussed about liver-directed therapies. As Dr. Oz mentioned, that was an option. We also discussed about Lutathera. At that moment, the data of the NETTER-2 was not out when this patient, and what we know now is that 177 lutetium DOTA is approved for low-grade neuroendocrine tumors. So the fact that we have this information that can also be used for higher grades is very important. But at that time, we didn't have that information. So this patient actually was enrolled in our clinical trial with Lutathera, 177 lutetium DOTA in combination with olaparib. Dr. Kunz will discuss more about clinical trials, but this is a study that is available here at the NIH. And the idea is that we want to make 177 lutetium more effective by adding olaparib, but that will be, and just to mention, LACNETS has also a clinical trials information and a video about the study. Please refer to that video if you have an interest in this study. Now let's discuss our second case. This is a 45-year-old female. At age of 40, she was complaining of intermittent flushing, postural hypotension. That means when the blood pressure drops when you go from lying down to sitting up, pre-syncope. So that's the feeling that you have when you faint or when you want to faint, and diarrhea. 5 years later, she was admitted to the emergency room with no clear etiology of the symptoms, and she was having worsening of diarrhea up to 20 times a day. Initially, her primary care physician thought that maybe there was an immune condition. She was sent to see an immunologist, and it was him who recommended further evaluation. And as we can see here, the plasma serotonin was very elevated, as well as the 5-HIAA was also elevated. She then underwent a CT scan of the abdomen, and we can see here that there is multiple liver metastases, which are the more darker area that we see in the liver. But maybe for further view, we can see the dotted scan, and the dotted scan also was positive as well, with the tumors having the receptors, and as we can see, the scan is also positive. And a question for Dr. Mittra: what would you recommend here, Dr. Mittra?
I think imaging-wise, it's exactly what we need. We, again, want anatomic imaging and the dotatate PET for staging. Since this is the initial diagnosis, it would be important to find the primary tumor, which, again, can be done usually with a combination of those two things. There appears to be something there in the mesentery, which would suggest there be a small bowel origin for the tumor. So that's something that would be important to find and can be helpful for the surgeons. But beyond that, it's clearly a very widely metastatic case.
And Dr. Singh, what are your thoughts about this case? We think is coming from this small bowel primary. So we know that serotonin and 5-HIAA is very elevated, but there was not an obvious mass on this scan. So what are your thoughts about that?
I think the primary needs to come out. There's no question in my mind. I think there's a mesenteric mass. So this is most probably a terminal ileum or a right-sided colon primary. So if you don't see it, I would still recommend surgical intervention based on the mesenteric mass and go and do a right hemicolectomy if there is truly a mass in the right colon or in the terminal ileum. So that's number one. Number two, I think you have too much liver disease. And this is not a liver that I could safely debulk to 70%. So I would, again, actively engage my interventional colleagues and my med-onc colleagues. I would approach this in a stage-wise fashion. You could just do somatostatin analogs and watch this patient after the resection of the primary. And if there's no progression of the metastatic disease, you can delay the treatment of the liver metastases to a later time point. However, what's tricky in this particular case is the fact that she has 18 to 20 bowel movements a day. Now, you could make a case in that sort of a setting to deliver with interventional radiology. That's definitely an option, and that's what we did about 10 years ago. Today, you have telurostat in your back pocket. So I've seen medical oncologists use telurostat to control the bowel movements as well, and then keep an eye on the liver metastases. So I'd put that question back to you and the interventional radiologist as to what your thought process is on this. Do you like to treat them up front, or would you straight go to IR?
I'm an interventional radiologist. I like to do interventions. So this patient is pretty symptomatic. And, as you mentioned, there's twofold goals of therapy, same as with our bland embolization procedures, is to not only to hopefully stop the growth of the tumor, stunt it, shrink it down, but also the second point would be for patients who are symptomatically affected by their tumors. And so in this case, doing a bland embolization, I think, would benefit this patient and has a high degree of sort of success when you're doing it for that purpose. So I would advocate for it. But as mentioned, I think it's also reasonable if for any reason we wanted to hold off and see if medications could control it.
As a surgeon, I think it's imperative to remove the primary tumor because I think that largely determines the progression of metastatic disease and gives you an idea as to how the symptoms are controlled after the resection of the primary tumor. And so in that sort of a setting, I would definitely recommend proceeding with a right hemicolectomy in this patient and then reassessing. And if the diarrhea continues to be a big impending issue, then I think the options are to consider systemic therapy with our medical oncology colleagues and alternatively interventional radiology to control the liver disease, which might be also participating in the secretion of the high 5-HIA.
Yeah, I just wanted to add, from my perspective as well, this is again why the NETTER-2 study was so powerful, because it was exactly in these types of patients who initially diagnosed, it was within the diagnosis that they were given Lutathera as long as they had high somatostatin expression, such as in this case. So I would throw that also into the mix as well, because in addition to controlling the tumor growth, it can definitely also help symptoms, and it can be given in conjunction with somatostatin analogs for additional symptomatic control. So just like all of these are options, and this is exactly why we have these types of multidisciplinary tumor boards to have all of these different perspectives and kind of choose the best path forward.
Absolutely. And as we all discussed, this patient underwent 2 radioembolizations. In this case, Dr. Oz did mention when is needed or what in terms of the difference between blind embolization or radioembolization. She also underwent surgery, as Dr. Singh mentioned, and underwent an colectomy. 2 separate tumors were identified, and 3 out of 12 lymph nodes that were resected was positive for neuroendocrine tumor. And pathology was consistent with a grade 1, well-differentiated neuroendocrine tumor with a Ki-67, more than 1%, but less than 3%. And she then underwent 2 blind embolizations, and the symptoms of diarrhea significantly improved. But then she was complaining of worsening shortness of breath. And here, the point I want to make is that every patient that have small bowel neuroendocrine tumors, where there is excess of serotonin and 5-HIAA, it's important to see a cardiologist and have a routine echocardiogram, surveillance echocardiogram, maybe once every year or once every 2 years, depending on how the clinical presentation of this patient is. But that can also, and the reason why I'm saying this is because when we see something like this, we need to consider about carcinoid heart disease, meaning that the hormone can also go to the heart valve and it can cause scar of the heart valve, and that can also then put a risk for the patient to develop heart failure. So I think it's important also that our patients with small bowel neuroendocrine tumors that has this excess of hormones that be evaluated by a cardiologist and have routine echocardiograms as well. And my last question for Dr. Oz, a lot of our patients are asking about histotripsy. So I think we understood that in this situation, resecting the primary was important. Doing the liver-directed therapy with embolizations is also important to consider in this patient for the symptoms. But we get a lot of questions about histotripsy. Maybe would you mind describing what is that and how this plays in terms of the management of neuroendocrine tumors?
Sure. Yeah, I'm glad a lot of people are asking me too. So I'm happy to chat about it a little bit. Histotripsy is a non-thermal. So non-thermal means doesn't rely on using heat or freezing to kill tumors. Mechanism of using ultrasound energy to ablate or kill tumors. It's also non-invasive. So it's very attractive because it's non-thermal and it's non-invasive. Most of the tumors that we've discussed today through our case presentations involve patients who had tumors throughout their liver. Histotripsy would be more applicable in situations where patients only had a few liver tumors, where we would consider doing what's known as ablation or percutaneous ablation, where we take a needle, put it into the tumor, and burn it away. Histotripsy would mitigate the risk of the needle puncture and also would allow us to potentially treat tumors that would be hard to treat with traditional ablation, meaning tumors that are next to blood vessels, bile ducts, which happen to occur a lot in the liver. So histotripsy is technology. We just received it. And so it technically doesn't allow us to treat any new patient per se, but it's another tool that we have available to us to treat tumors the way that we think of when we do ablation. So it's a very exciting technology. One of the other final things I'll mention about it, it's very interesting, unfortunately doesn't apply yet to neuroendocrine, but it seems that when you do histotripsy, it promotes a very immunogenic response, meaning when you kill the tumor, it basically disintegrates the tumor such that all the tumor antigens are released. And it really basically, sort of to sum it up, it wakes up the immune system very much. So there's a lot of interest that you can get what's known as a non-target response. And that's particularly in cancers where we use immunotherapies. So there's also some excitement there with histotripsy as well. And because it's so new, we don't really know a lot of the answers yet. But now histotripsy is FDA approved. There are at least 10 centers that have the technology and are offering it and evaluating patients. But yes, it's a very exciting time because of having that technology available to us.
One quick question. On
Sure.
that same thing, how big a tumor can you treat with histotripsy, and what's your size cutoff at this point?
Yeah, a great question. So histotripsy is very similar to percutaneous ablation in that the sort of maximum size that you can sort of do in one session is about 4 centimeters. So we typically will target tumors. If we want to treat the whole tumor, we always want to have some margin. So we'll typically treat a tumor that's up to 3 centimeters. It doesn't mean you can't treat tumors that are larger than 3 centimeters. You would just have to do multiple treatments, of that same area. So right now we're probably limiting it to, at least in my practice, limiting it to patients who would be eligible for ablation. And this would be an alternative to ablation.
Any major disadvantage or complications or associated with histotripsy?
Yeah, I would say the major disadvantage is currently we can't get to every tumor the way that we can get to with percutaneous ablation, largely because this is a technology using ultrasound waves essentially to create cavitation within the tumor. We have to have a good sonographic window, so we have to be able to see with an ultrasound very well, and there's some more physics to it, but we have to sort of in a geometric way be able to align the robot so that the tumor is very well visualized. So that limits sort of the parts of the liver that we can treat. With that said, there's a lot of technological updates coming to the system over the next year or two that will hopefully be able to allow us to treat actually any tumor. We're a little bit away from that, but right now we're largely limited to tumors that you can mainly see with an ultrasound from a subcostal approach. So meaning, if you take the ultrasound, you can only see the tumor from under the ribs.
Thank you so much. It's really been a fantastic panel of experts. Thank you so much, Dr. Mittra. Thank you so much, Dr. Oz and Dr. Singh. I really appreciate your expertise and everything that you give for patients. It's been an honor for me to be with you all today. And with that, we close this section. Thank you.
Thank you so much.
Thank you.